Hello, and welcome to today's webinar. I am Robin Brumble, a registered nurse and CLL Society's Director of Scientific Affairs and Research. At CLL Society, we are dedicated to bringing credible and up-to-date information to the CLL and SLL community because we believe smart patients get smart care. As a reminder, you can re-watch all of our educational programs by going to the section of our website called Education on Demand. This program was made possible through support from both our donors and our industry partners. At this time, I would like to introduce our moderator. Thank you.
Thank you, Robin. I'm Dr. Brian Kaufman, co-founder, Executive Vice President, and the Chief Medical Officer at the CLL Society, and a retired family physician and a CLL patient myself. And I want to welcome you all to today's event. We are joined by Cyril Sultan, who's our Director of Government Affairs and Public Policy at CLL Society, and she'll be giving the bulk of the presentation today. Together, we'll be presenting why policy and advocacy work is so important and what CLL Society has accomplished so far and what future challenges we face. Thank you for your involvement, your participation, and let's begin. So, why policy matters, understanding how your CLL/SLL journey is affected. And I think this is an area that's new for a lot of people, and they don't think about this a lot, but policy affects everything in terms of how our treatments are developed, how they're accessed, how new innovation occurs, and we'll share some insights on that. We're going to explain what policy and advocacy work is, explain why CLL Society decided to engage in policy and advocacy. We're going to review the structures and focuses of our work, the institutions we put together. We're going to give some examples of our past successes. We're going to share a personal story of why policy and advocacy matters to CLL/SLL patients, and we're going to point out present and future challenges. So let's begin. So CLL Society founded our Policy Institute, and it's focused on three main pillars. The first are the needs of the immunocompromised, and we've heavily engaged in that. The second is access. Drugs are great, but if you can't afford them, if your insurance doesn't cover them, if they're not available, if they're not part of your formulary, what good does it do you? And the last is innovation. I and many other CLL patients are alive today because of breakthroughs, cracking the biology and understanding the nature of the disease. And those innovations in new therapies have fueled the progress that we've seen and made CLL a much more manageable disease with a much better outcome. So let me give you a little bit of our history of advocating for the immunocompromised. We worked tirelessly with several government agencies and changed the definition of who was immunocompromised. The old definition of who was immunocompromised were patients who were receiving active therapy for their hematological malignancies. But we were able to change that definition to say those who have a hematological malignancy and actually get them specifically to list chronic lymphocytic leukemia and are known to have a poor response to COVID-19 vaccines or an increased risk of severe COVID, regardless of their treatment status for their hematological malignancies. This was a huge change and allowed us access to pre-exposure prophylaxis when it was effective and other helpful therapies. This is a huge win, and it's going to have many implications going forward because the COVID story and respiratory infections and other problems are not all behind us. So just to keep in mind why this is so important, vaccine responses are often much lower in CLL patients who are moderately or severely immunocompromised. This is true regardless of their treatment status, even if you're treatment naive, even if you're in a deep remission. Because of this, new vaccine schedules are developed for CLL patients. We know some patients who are immunocompromised have prolonged symptomatic COVID with evidence of ongoing SARS-CoV-2 replication. And because of this, there's new therapies being explored. Longer or additional courses of Paxlovid are being explored. Same with remdesivir. High titer COVID-19 convalescent plasmas from vaccinated patients who recently recovered from COVID. And this is called this sort of double hit, this double exposed patients are seeming to help, at least in some cases for CLL. These are all new things that wouldn't be available without the recognition of the immunocompromised states of the CLL patients. We've also worked on the ODAC committee. So the ODAC is the Oncology Drug Advisory Committee, and they determine the safety and efficacy of marketed and investigational drugs for use in cancer. And it was clear that the ODAC wanted to get rid of PI3 kinases for CLL and SLL. And the two that are approved in CLL are duvelisib and idelalisib. I was lucky to be able to speak at the ODAC meeting for keeping this drug alive. We had over 50 CLL experts from around the world sign on to a letter that was sent to ODAC saying that they wanted to keep these drugs around. We had hundreds of you patients respond and send letters to ODAC. And both of these drugs are still available today. Will they be available tomorrow? No promises. Were we the only factor in that? Absolutely not. Other people contributed. But I do think that we were a factor and influence in this. So what I'm saying is we've had some significant successes. Let me talk a little bit about the Inflation Reduction Act, or IRA, which you've heard of. And it has three aspects here. And I'm just going to touch on these briefly because Syra is going to go over them in much more detail. The big and wonderful news is that first one, out-of-pocket cap. So starting in 2025, there'll be a $2,000 limit on the out-of-pocket expenses for all drugs. This is an amazing situation. This doesn't control the cost of the drug to Medicare, but it controls the cost of the drug to you and I as patients who are on Medicare. Still, if you walk into the pharmacy and you have a $2,000 bill, that can be difficult for a patient. And that's what smoothing is about. And essentially, smoothing says you can spread that $2,000 over the 12 months. But there's issues with that, and I'm going to get Syra to explain that in more details. And the last is direct price negotiations, which is how they're hoping to pay for the out-of-pocket expenses, cap, and for other things. And our concern is this has some unintended downstream consequences that are going to be disproportionately affecting the rare cancer community, including CLL, but also friends with other even rarer cancers. So these are our areas of interest. So the CLL Society started a coalition called PERC, Protecting Innovation in Rare Cancers and Coalitions, recognizing that a lot of these are very small organizations. And we took the leadership in this when we saw others weren't doing this to safeguard innovative care. We need new treatments. We all know that we have a couple wonderful treatments, but when we run through a couple classes of drugs, we're out of luck. And PERC is to try to help us encourage the development of new drugs. We've already seen drugs pulled from the market or pulled from development because it just doesn't make financial sense for their development. So we'll talk more about this later. Here's my personal story. And a lot of you know this. I was diagnosed in 2005. In 2008, I had a bone marrow transplant that failed. I had about a 5% chance of a 5-year survival. By 2011, I'd run out of options. My best choice was a clinical trial, a breakthrough drug. And you can read about this drug in that book that I list, For Blood and Money. And I'm actually in that book. And this drug saved my life. And then my life was saved again by Lysocell, the first CLL CAR T, not approved yet, but likely to be approved. And I'm now in a trial for epcoritamab, which is a bispecific T-cell engager. And I happen to be the first CLL patient in the US on this trial. So talk about being on the leading edge of the tip of the spear. I've also been in a clinical trial for AZD7442. If not for the innovations of these newly discovered therapies, I'm not exaggerating, I'm not being dramatic, I would have been dead years ago. So innovation in CLL therapies has helped many. Many were saved by ibrutinib, and if there wasn't ibrutinib, there wouldn't be acalabrutinib and zanubrutinib and pirtobrutinib. In some patients, we switched to ibrutinib to newer BTKs due to drug intolerance, and many have had years of remission as a result. Venetoclax is another great option that we have. And multiple patients have used PI3 kinases either to control their disease or serve as a bridge until they can get other therapies, such as CAR T. And as I said, Pirto is now being used off-label with great success for a lot of patients. All of these innovations happened in a somewhat different era that we're moving into now. And CLL Society wants to encourage the development of new innovation. So we need more opportunities, not fewer. Once BTK drugs and venetoclax fail, options are very limited with limited durability. New therapies are desperately needed, and we need to ensure the pipeline stays open and active. We need options that are accessible, approved, and with a range that people can pay for and covered by insurance that are affordable. This is some of what we are continually advocating for at the CLL Society's Policy Institute. And with that, I'm going to turn this over to Syra. And Syra is an attorney by training and an expert at what goes on inside Washington, and has been a tremendous member of the CLL Society team in terms of helping us understand and develop the proper approach to policy and advocacy. Syra, all yours.
Thanks, Brian. My name is Syra Sultan. As Brian mentioned, I'm the Director of Policy and Government Affairs for the CLL Society. I'm going to talk a little bit more extensively about issues that Brian raised earlier. So as Brian mentioned, the CLL Society's Policy Institute, which was created earlier this year, is focused on 3 pillars. And these are not distinct pillars by any means. And as you can see by the arrows indicating here, that there's a fair amount of overlap between these topics, but I always find it easier to understand by example what each of these means. So I thought maybe I would walk us through how we got here and then what some of these mean. So in creating a policy institute for CLL Society, we looked at the landscape of all the policy work being done out there today by the White House, by the agencies like CDC, CMS, FDA, acronyms that we can walk through if you'd like, and of course also by Congress. We mapped that against what we know about the needs of the CLL community and divided the work across these pillars. We then looked at what other organizations were doing to see where we could be efficient, where we could simply support their work, follow along, monitor things that maybe don't rise to the same level of interest or concern for the community as other issues do. So we exercised some discipline and broke these issues down into where we would monitor, where we would follow, and of course, where we would lead. Finally, some examples to explain what these columns mean. So the needs of the immunocompromised are maybe the most self-explanatory, the column on the left. By way of examples, we have been working on making sure that HHS is rolling out the vaccines appropriately, making changes in the way FDA approves new vaccines or treatments for COVID, for example, that would be appropriate for the immune-compromised population. Where this column overlaps, I'll mention with the innovation column, is where we talk about things with FDA that relate to making it easier or understanding the benefit risk sort of balance for immune compromised populations differently as they look at how best to approve new therapies and treatments. Then I'll switch over to the access column, and I'll use this one as an example in future slides to explain a little further. But access is generally a term that refers to, at least in policy, in the policy world, as things related to payers, insurance companies. So think about whether your insurance is from Medicare or Medicaid, or commercial insurance through your employer or through an ACA plan. We're always scanning the horizon for what stakeholders are doing. New proposals, policy proposals, as I said, by Congress and others. CMS, which is the agency that administers the Medicare and Medicaid program. These are all places where public policy is being changed or added or proposed. And this pillar allows us to focus on those changes as they affect the CLL community. And then finally, innovation, which is usually a word that refers to what FDA is doing, the Food and Drug Administration, in terms of bringing new treatments to market, or I should say, approving new treatments as being safe and effective for bringing to market. So I want to focus today a little bit on one of the topics we've been spending a lot of time on in that middle column called access. And if you'll recall, that column or the word access refers to what the payers or insurance companies that CLL patients presumably have in deciding how they will cover various things and pay for various things that the patients need. So Congress passed a new law last year called the Inflation Reduction Act. It has much to do with inflation reduction, but those aren't really the portions of the law that we concern ourselves with. There's another portion of that law that relates to changes in the Medicare program. So, as I mentioned, CMS, the Centers for Medicare and Medicaid Services, has created an entire division inside of the agency to implement this new law. And there are, I would say, several pro and con implications for our community in this law, and we've spent a great deal of time analyzing those implications for the community and assessed which pillars of the Policy Institute not only does this fall into, but also, as I mentioned before, where are others doing work that we can simply support, so we're not duplicating efforts and we're leading where we see gaps. This law generally made changes to the Part D program, Part D like David, the prescription drug program in the Medicare program, in the larger Medicare program, as well as in Medicare Advantage programs. That's where Medicare Part C and D are blended together, where you get your medical as well as your pharmacy benefits through Medicare. So in this area, we specifically saw not only that we were not able to follow or monitor because the needs were too important of the CLL community, but also that there was a significant gap in the work being done, both in assessing how the the patient population was impacted, but also in advocating for changes as appropriate. So the CLL Society not only commented on its own to the government and to the policymakers, but realized that what we had to share was very important to the larger rare cancer community as well. And so not only could we speak as CLL Society, but we could have a louder voice together if we shared our findings with the larger rare cancer community and asked all of those groups as well to participate with us in the work we were doing. The purpose of the PERC, named for Protecting Innovation in Rare Cancer, Rebalancing the IRA. The purpose of the organization or the coalition is to educate not only ourselves, but our patient communities, our physician communities, but to also applaud where we can. There are, as we'll discuss in a moment, some really important, helpful parts of the IRA, as well as to prepare for what is coming, and then finally to fight against the things we find challenging for our patient community. So to give you 3 examples of what is in the Inflation Reduction Act that affects our patients, the first relates to out-of-pocket cap, the second to smoothing, which these are terms I'll explain in just a minute, and then finally direct price negotiation of drugs. So to take the first on out-of-pocket caps, beginning in 2025, if you are enrolled in the Medicare Part D, like David program, your out-of-pocket costs will be capped at $2,000. This is new. Practically speaking, though, it depends really on what one's Part D plan is to realize what the benefit will be to you. So for example, you might be in a plan today where you pay a deductible. That deductible cannot be greater than $505 in 2023. Your plan then may require that you participate in cost sharing or co-insurance based on the price of the drug that your physician says you need, your oncologist says you need. For cancer patients, often those drugs are on something called a specialty tier, which means that patients are left paying upwards of 25 to 33% of the price of the drug. So it can be quite costly. And finally, there's a catastrophic phase of your plan today where you pay nothing. So if you look at all these costs that you incur today and you compare them to the $2,000 cap that will kick in 2025, you begin to see that you might be one of the patients that benefits from this new cap. The Medicare program envisions that about 20% of Medicare beneficiaries will in fact reach this cap or exceed this cap. And we expect that CLL patients will, of course, because of the costly cancer drugs we take, will largely be in that 20% and therefore will in fact benefit from this new cap. So that's what the out-of-pocket cap is about. And then secondly, there's a new program called smoothing, or it's now been renamed to be the Medicare Prescription Payment Plan, or MP3 as it's called by some already. This is a new program that will allow patients to spread the out-of-pocket cost, that $2,000 starting in 2025, across the entire calendar year. So if you participate in a Medicare Part D plan or a Part C plan, one that brings together both your medical needs as well as your prescription needs, in those programs, you will have this new cap of $2,000. That's great, but often when you go to the pharmacy for the first time, say in January or February, you're not only paying your deductible, but maybe you may be hit by a very expensive, let's say $1,000 drug at the pharmacy. Your cost share would be $1,000. We hear often that patients have to leave those drugs at the pharmacy because they're unaffordable or they can't afford such a large amount all in 1 month. Well, this new program would allow you to spread the cost of that $1,000 drug across the entire 12 months if you're picking it up in January, or in whatever months are remaining in the months of in the month you pick it up. So for example, if you're picking it up in June, you have 6 months to spread the cost of that drug over versus picking it up in January. CLL Society is of course very supportive of this program and is advocating in support of details that will be helpful to our patients as the program is rolled out. So unlike the out-of-pocket cap, which we talked about a moment ago, which is automatic, this so-called smoothing or MP3 program is one that patients will need to opt into, which means patients will need to understand that the program is available to them, when it's available, how it works, and all those details are yet to be worked out, both what the details are, as well as how they will be communicated to patients. So for example, as we look at the initial rollout or initial proposed details of how this program will work, there are many things that occur to us that could be difficult for patients and need to be fixed or amended in the year the program begins or soon thereafter. Some examples of that include, we feel like there should be an option for the patient to opt into the program right at the pharmacy counter. So they're at their pharmacy, they get that first $1,000 drug coinsurance that they can't afford. They did not enroll in the program when they first enrolled in their Part D plan. And so they should be able to enroll right there at the pharmacy and be able to leave with the drug without having to pay for it at the counter, but be billed for it later over the course of 12 months or how many ever months are remaining in the plan year. We would also like to show, for example, or would also like to see the program include an auto renewal after the first month. I'm sorry, after the first year. While the law does require opt-in, it doesn't require it year on year. And so we'd like to see CMS consider that after the first time a patient has opted in, that renewals become automatic. That is how traditional Medicare works, for example, and that's how we'd like to see this program work for our patients as well. There's also a grace period if you are not able to make your monthly payment. This is something that we at CLL Society and other patient groups have fought hard to get, and we were happy to see it in CMS's proposal. The grace period, though, is for 2 months, and we would like to see it be 3 months. There's already precedent for 3 months in the accountable care, I beg your pardon, in the Obamacare plans that already exist. I won't go over each item on this list, but I'm giving you a flavor of the kinds of things that CLL Society is analyzing and seeing ways in which we could improve the program by the time it rolls out for patients. So here's an additional list of some other things we see that could be improved for patients as this program rolls out. One is we would certainly like to see any appeals on the participation in the program be made very easy. We'd like to make sure that every Part D plan is using a uniform process, uniform forms, putting them on the same place on the website, as much standardization as we can ensure that patients find it easy to participate. Each of the Part D plans also has to roll out a set of data that they have to collect about this program. And so we want to have CMS pay attention that if there's unusual amount of dropout rates of the program or any other red flags, that the plan needs to course correct, because clearly an unusual amount of dropout rates or any other unusual outlier data would suggest that the plan is not doing everything it can to make it easy for patients to participate in this smoothing program. The third part, the third bucket of items in the IRA that I'd like to discuss today that CLL Society is tracking carefully is that for the first time ever, the government will be able to directly negotiate with drug companies the price of some drugs, some selected drugs. That program will begin in 2026. On September 1, earlier this year, the first 10 drugs were selected for government price negotiation. CLL Society has been watching carefully for this list. Only one cancer drug was included in this first 10 list, and that was Imbruvica. That will have implications for our patients, not only because the government will be, over the course of the next several months to a year, be negotiating the price of that drug, but it will decide that where Imbruvica will fall in the formulary or the list of drugs that your Part D plan will make available to you. It will also affect, sort of have a ripple effect of what other drugs will be available to you in light of the fact that Imbruvica is available. And so we will be watching all that very carefully and participating with the government in filing comments with the agency so they know what is important to CLL patients. We'll be listening to the Imbruvica listening session coming up on November 6th. And then, as I mentioned, what they're calling a maximum fair price will be announced in September of next year. And then finally, in January of 26, these maximum fair prices will go into effect. Thank you.